Good afternoon, everyone. Hi, Maria. How are you? Are you able to hear and see us okay? Very good. Well, good afternoon, everyone. Thank you all for joining today's webinar, Increasing Access to Care in Texas Communities with Telepsychiatry. On behalf of Maria Rios and the Texas County Council of Community Centers, we're very excited to be a marketplace sponsor. We are Array Behavioral Care. Array is the largest telepsychiatry service provider in the country, and we have a mission to transform access to quality, timely behavioral health care. We offer telepsychiatry solutions and services across the continuum of care, from emergency rooms to clinics and direct-to-patient homes. For more than 20 years, we've partnered with hundreds of hospitals and health systems, community healthcare organizations, and payers of all sizes to expand access to care and improve outcomes for underserved individuals, facilities, and communities. We are proud to be an industry pioneer and established thought leader. We've helped shape the field, define the standard of care, and advocate for improved telepsychiatry-friendly regulations. Today's presentation will cover how Texas Council members can implement or expand their telebehavioral health programs to meet the increasing demand for behavioral health services within our Texas communities. Good afternoon again. I am Scott Baker, and it's a pleasure to be here, and thank you to the Texas Council of Community Centers for having us. I am the Vice President of Partnerships in Texas for Array Behavioral Care, and very excited to host and to give today's webinar. Before we get started, I'd like to go ahead and cover a few housekeeping notes. All participants have been automatically placed in listen-only mode. If you have questions during the presentation, which we hope that you do, please use the Q&A window within the Zoom video platform. We will hold all the questions until the end of the program, and time permitting, we will respond to as many questions as we can. Please also note that we will be sending out a copy of the presentation slides and the recording within the next week. Please feel free to share the presentation and notes with colleagues interested in the topic. So a bit more about my background. I've been working in the telebehavioral health space for just shy of 10 years. And I've been fortunate in that time to have worked directly with payers, health systems, hospitals, community mental health agencies, federally qualified health agencies, and a variety of other healthcare settings to design, implement, and maintain telebehavioral health programs across the continuum of care. So we're here today to provide valuable perspective and insights into the why, the where, and the how that community organizations in Texas can leverage telebehavioral health to enhance your current service offerings and ultimately drive value in clinical, operational, and financial aspects for the patients and communities that you serve and for your organizations themselves. A bit about the agenda. We'll give an overview of Array Behavioral Care. We'll talk about the landscape for behavioral health in Texas. And then we'll do a deeper dive into operational considerations for clinic-based telebehavioral health programs, talk about the exciting work being done in collaborative care these days, and then talk through some implementation and ROI considerations. We're also eager to hear your questions and respond to them at the end of the presentation. So it's no secret. The disparity between the supply of good quality behavioral health clinicians and demand for the services that they provide persists. Some would say that that disparity has widened in recent years. More than 55% of counties across the nation have no psychiatrists, and the shortage is expected to increase over the next few years to reach as many as 15,000 psychiatrists short of the demand for those services. I would ask you to consider what happens when 60% of adults with mental illness don't receive care in the previous year. Does that care shift upstream to the PCPs, or do those individuals go without care? Most notably is the statistic on your screen now, which says that 1 in 3 Americans will have mental health or substance abuse issues this year. That number was 1 in 5 prior to COVID. And so we're certainly seeing an increased demand for the care that we at Array and your organizations exist to serve. So who are we and why do we exist? So fundamentally speaking, Array Behavioral Care is a large behavioral health practice. We leverage technology such as telehealth to deliver care that is steeped in measurement-based to be able to inform clinician perspectives and calculate and report on clinical outcomes, to deliver care that is very needed from highly qualified and licensed clinicians so that the patients that we serve and the organizations that we partner with are able to realize quality outcomes. We're fortunate to deliver care truly across the continuum in behavioral health, and we're fortunate to be the largest and longest running behavioral health telehealth organization in the country. We recruit and retain and employ top clinicians across the country that enable us to deliver quality and consistent care. Again, it's no secret that our behavioral health system in general is strained. It's strained and is resulting in insufficient behavioral health capacity. And that lack of behavioral health capacity has led to barriers in patient access. And when there's barriers to patient access, care can become delayed. And when care is delayed, that can lead to increased cost and decreased patient outcomes or patient wellness. Those increased costs can be attributed to the downstream effects when behavioral health issues are untreated or care is delayed. We've certainly seen a lot of change with the pandemic. The pandemic has increased demand, has increased the acuity of that demand, and has shifted care to settings that it was not traditionally delivered in before. We saw many organizations at the beginning of the pandemic lacking experience, comfort, policies, platforms, that infrastructure to deliver care directly to patients in their homes. And we were fortunate to be a part of the solution with helping to move care to the patient demand, reduce the acuity, and do so in a safe and effective manner. A bit more of Array Behavioral Care at a glance. We are an organization that is steeped in bricks and mortar behavioral health. We started delivering telepsychiatry in the late 90s out of a bricks and mortar outpatient behavioral health practice that still exists today. And so we have over 20 years of experience delivering care. Although the first setting of care that we were delivering telepsychiatry into was acute, we've expanded across the continuum. Today, we currently service partners and patients in just shy of 40 states across the country. And we're very fortunate to be seen as the employer of choice among psychiatrists and therapists looking to expand their practice and reach patients through telehealth. Today, we employ, and I do mean W-2 employ, well over 500 behavioral health clinicians. The majority of those clinicians are psychiatrists and child psychiatrists, but we also work with psychiatric nurse practitioners in some settings and states and licensed clinical therapy level professionals. We were quite busy, as I imagine you were as well, in 2020. We delivered almost 400,000 sessions last year in the midst of a global pandemic. We deliver care exclusively through real-time face-to-face video conferencing, and we do so generally through 3 different operational models. The first model is called on-demand care. On-demand care is what we got our start doing in the late 90s, and is, operationally speaking, is a team of clinicians, oftentimes a team of board-certified psychiatrists and or licensed clinical therapy level clinicians who are available in a coverage model, oftentimes 24/7, 365, to respond in an as-needed fashion to intervene. Usually you'll find on-demand care in acute settings, solving problems such as psychiatric boarding, inappropriate reliance on scarce psychiatric inpatient resources, or initiating stabilizing treatment for patients who are seeking care in the ED or in the med-surg floor. The second model of care that we deliver services through is what we call scheduled care. Scheduled care is much different from on-demand care, such that scheduled care allows for a remote but named, consistent, highly integrated clinician to become a member of the treatment team within usually an outpatient setting like a clinic, but can also be used for inpatient settings for rounding, where the scheduled care clinician is carefully selected based on the clinical needs and acuity of the patient population, the cultural demographics of the community, and the preferences of the organization that they're serving. And these remote clinicians are able to carry a caseload of patients and integrate and collaborate with the treatment team on the ground. The scheduled care is typically deployed to solve problems such as, help. We don't have enough clinicians or clinician capacity to serve our community. And as a result, we have a long wait list to be able to see a psychiatrist or a therapist, or we need subspecialty expertise like child psychiatry or geriatric psychiatry or licensed clinical social workers with specific areas of expertise to serve the needs of my community. And I've been unable to recruit or retain a high enough quality or consistent enough capacity of those clinicians to serve my community. The third model of care that we deliver services through is what we call at-home care. At-home care is a direct-to-consumer practice that essentially takes the tenets of what you would find within an outpatient behavioral health practice, psychiatrist, child psychiatrist, licensed clinical therapist, delivering initial evaluations and ongoing med management and therapy directly to patients in their homes. Our at-home care service line is in network with some commercial and managed Medicaid entities across the nation, and frankly gave us the chops that we relied upon when COVID hit to be able to safely, effectively, and efficiently deliver good quality psychiatry and therapy directly to patients in their homes. That was a competence that we brought to our scheduled care clinic partners that was very valuable in helping to quickly ensure that there was no gaps in care. So I struggle on this slide to rank Texas as anything less than #1, which I think we all agree Texas is #1 in our hearts. But the reality is Texas is ranked #3 in the nation in the prevalence of mental illness in 2020. That's 3.3 million adults with mental illness. Unfortunately, 2 million of that 3.3 million didn't have or didn't access care. 61.7% of adults with mental illness did not access care. And I'm sure there's a litany of factors involved, but maybe it's because 175 counties across the great state of Texas didn't have a single licensed psychiatrist in the years leading up to the pandemic. Texas currently ranks 38th out of 50 in terms of rate of access to behavioral health care for adults. And while that's certainly not something to be proud of, I think what's even more concerning is the trend that has led us there. Because in 2012, Texas was ranked 33rd. And so it has slipped in the last 8 years from 33rd to 38th in terms of access to care. And possible factors leading to this drop in ranking is increase in suicide rates across the state, increase in adults with mental illness reporting unmet needs for treatments, and reduction in access to care. It's not all doom and gloom. We are here to help, and we are here to partner with the great organizations like yours to deliver this care. So let's do a deeper dive into applications of telehealth, specifically our scheduled care model in community settings. And so I think let's first lay the groundwork. So scheduled care, telepsychiatry, and telebehavioral health services are delivered with great attention to consistency and continuity of care. These programs really rely upon that appropriate clinician match. You don't just want a clinician with a pulse and a license. You want a clinician who really works with your team and has the appropriate training and expertise to meet the needs of your patient population. And you need those clinicians to do that in a manner that minimizes disruption, works within the familiar workflows and structures that your team relies upon and your patients have come to know and trust. Scheduled care is typically delivered from behavioral health prescribers like adult and child psychiatrists, as well as licensed clinical therapists such as counselors and social workers. The work that they do is not dissimilar from what you would ask a clinician of that experience and licensure to do if they were physically there in your office seeing your patients. So scheduled care services can be deployed to conduct initial assessments, therapy and medical assessments of patients, to conduct ongoing medication management of behavioral health patients, to deliver ongoing therapy services for patients, as well as to participate, if necessary, in administrative duties, medical directorship, participate in treatment team meetings. Involvement of the remote clinician in treatment team meetings is really critical to the success of a partnership here with Array and community-based organizations. Treatment team meetings are a great foray into the team element. Really, these teams can thrive when the remote psychiatrist and or the remote therapist are regularly reviewing cases and collaborating with stakeholders physically on the ground within these clinics. So I would ask you to reflect on where are your gaps or where are your opportunities within your organization and within your community. Consider that maybe this would be the patient experience. Maybe you're very proud of the experience that your patients have when they come to your organization, when they interact with your staff, and you're reluctant to rely on external resources for patients who have needs that you're unable to meet in a timely fashion within your organization. Wait times are such an obvious symptom of lack of clinical capacity. What happens if a patient has to wait 3 weeks or 3 months to receive the care that they're coming to you today to receive? And then increased engagement and retention. Oftentimes we think about this about patient population, right? When a patient reaches out for care, we do everything we can to convert that patient and keep them engaged in care so that we can get them better and we can keep them better. But engagement and retention also refers to your staff, which are so critical to the ongoing operation and delivery of care that you do within your organization. And we oftentimes hear how stressful and frustrating it can be when your organization lacks the capacity or the areas of sub-expertise to really truly meet the needs of the patients who are coming to be served by your organization. So let's talk about a typical workflow of what a scheduled care clinician, how they would work within your team. And so I think what you'll find here is that it really meshes well with the existing and typical workflow of a patient who would be engaging with a clinician, like a psychiatrist or a therapist that's employed and physically present within your clinic. And so, since the remote clinician is working with you in your electronic medical record, prescribing through your e-prescriber, you would use the same systems for scheduling patients to be seen by the telehealth clinician as you would if you were scheduling them for an in-person provider. The difference here is education. This is a critical part that we focus on very strongly during implementation and ongoing management of our partnerships, is ensuring that there's very effective education that occurs, whether it's at the front desk within your administrative staff or whether it's during care handoffs from your other clinicians. But we really want to make sure the patient understands what to expect and has the opportunity to ask questions to ensure that they are comfortable receiving care via telehealth. For the last 21 years that we've been doing this, we've been delivering care when working with community organizations when that patient comes into your facility for that appointment, but also consider how steps 2 and 3 are now delivered directly to patients in their homes in some settings. And so just as a patient over the last year may have gotten ready for their appointment, reminded for their appointment, even if they weren't able to get in the car and drive to your facility because of COVID, the same workflow would apply if the clinician is one of Array's skilled clinicians that's a member of your treatment team. Step 4 is important as well, because if the patient's presenting in your physical clinic to receive care from the telehealth clinician, you do need some level of presenter or facilitation to help ensure that patient is greeted and brought back to the appointment. If it's their first appointment, they may have been asked to complete paperwork in advance of the appointment, or if they're coming back for a follow-up, they may need to update their records. And so ensure that there's consideration within the workflow for facilitation. The session occurs, if it's being delivered within your physical clinic setting, we have a lot of best practices that we're eager to share with you about where to place the lighting, how large the monitor should be, how to make the patient feel comfortable, ultimately how to replicate what that patient would expect if they were to sit down in the room with a psychiatrist in person or a therapist in person. We have a wealth of experience and best practices to share to ensure we're able to replicate that setting for the patient. And then importantly, also important is the back end. After the session is complete, in some cases, it's really medically necessary to ensure that that patient is scheduled for a follow-up appointment in the right time frame, or to ensure that that patient understands what medications are prescribed or what the treatment plan is for the patient. And so that's another area where facilitation and close integration with your staff is really critically important. I would also ask you here to consider some ROI elements or consider some operational and staffing considerations here, right? So consider what is the ideal ratio of therapists to prescribers like psychiatrists. Oftentimes we'll see that the symptom of reduced capacity is a long wait time. But when you really reflect on and analyze your current staffing mix, you'll find that there may be insufficient psychiatrists as it relates to your number of FTEs of therapists. We'll oftentimes see organizations like yours endeavor for a 4-to-1 ratio, 4 therapists to every FTE psychiatrist. But it may be different depending on the acuity and the nuance of your patient population. I would also ask you to consider the maturation of each clinician's caseload. When you're thinking about a prescriber like a psychiatrist or a child psychiatrist, from day one, 100% of that clinician's caseload is going to be initial evaluations. And so typically when we're working with an adult population, initial evaluation is an hour. With a child population, it's typically an hour, sometimes it can be 90 minutes. And then as that caseload matures, as you flash forward maybe 3, 4, 5 months in the future, you're starting to see more of those patients come back for follow-ups, follow-up med management appointments. And maybe you approach a 50-50 case mix where 50% of that FTE clinician's time is still processing initial evaluations, but the other 50% of the caseload is now working through, say, 20-minute med checks. And then ultimately, we typically get to a point where the caseload is more of a 20-80 mix. There's always going to be some level of attrition, whether patients fall out of care or get better and able to be managed by a PCP. But 20% of that mature caseload may be from initial evaluations, and 80% may be from ongoing med management. And then go and consider your funding sources, whether it's block grants, whether it's fee-for-service reimbursement, and you can really start to see the ROI impacts of a single FTE psychiatrist, for example, as that clinician starts seeing all initial evaluations to 50-50 to mostly med check follow-ups. And then also consider the trickle-down impact to the caseload impact to the therapists that are engaged in care from both the telehealth psychiatrist and or the telehealth or in-person therapist, and the ROI implications therein. I'll tell you, we're excited about a lot of stuff these days, but we and the industry in general are really quite excited about how well collaborative care and integrating behavioral health within primary care settings is really taking off. Now, there's a variety of different ways to deliver collaborative care or integrated behavioral health. What we're focusing on with this slide is really the impact model, the AIM center model of collaborative care. This is a model that is really designed to enable primary care physicians to keep patients within their direct care, but also provide comprehensive behavioral health services like assessments and interventions, treatment and management of these patients. The model of behavioral health integration that we've seen a lot of success in relies on a dedicated virtual behavioral health care manager who's regularly consulting with and has access to a consulting telehealth psychiatrist and is pulling from and deploying a digital library of validated scales, standardized scales for diagnosis, assessment, behavioral intervention, and informing treatment. And then I think part of part of the secret sauce, right? Part of the additional value that we're fortunate to be able to provide in a model of care like this is right here, this offshoot, a raised virtual practice for ongoing care of complex cases. What we've seen in our experience is that you are able, if you have the right selection criteria, you are able to select the right type of patient to enroll in a registry, to enroll in collaborative care. But there's also other patients within these practices. And there are at times patients within that collaborative care contingent that may require direct intervention for more complex cases. And that's an area that we're fortunate to be able to engage our at-home direct consumer practice to be able to catch those patients, deliver them timely, qualified, and specialty care. Typically within this general collaborative care model that we're speaking of here, we hold responsibilities such as maintaining a registry of the collaborative care patients, actually executing and sending digital assessment tools and screenings, regularly meeting on a weekly basis with the larger care team consisting of the PCP and stakeholders on their ends, documenting directly within the PCP's EMR treatment recommendations and expert diagnosis and other guidance, and then providing brief interventions, CBT, direction to care like SBIRT from the behavioral health care manager. This is really a model of care that we're excited to see take off in Texas and across the country because of some of the reasons we mentioned earlier. The disparity between supply of good quality clinicians and demand for their care continues to widen. And collaborative care is a great way to have a one-to-many impact from the scarce resources, such as the psychiatrist and the behavioral health case manager. There's oftentimes a strong desire on behalf of the PCPs to keep those patients, but have more resource, more support, and more comfort in the diagnosis and the treatment recommendations. Collaborative care is an excellent way to deliver that. We've also seen that, that our model of deploying collaborative care, leveraging telehealth, allows this important model to get to really the full spectrum of PCP or pediatric practices, some of which may not have been enrolled before, right? You think about the spectrum of PCP practices in terms of size and sophistication. It would be easier to see collaborative care deployed within the larger practices with more physicians. But there's also a need within the smaller practices, maybe a single PCP. And we found that the scalability that is offered by leveraging telehealth brings collaborative care to all of those practices. So the partnerships and programs that we've talked about today require thoughtful implementation, and they also require ongoing proactive account management. And so it's important to consider some of the back office work that's necessary to make this effective. And so we've really become quite adept in our 20 years of experience at managing the licensure of the clinicians, their ongoing education requirements, the credentialing that's needed to get these clinicians enrolled within your payers and ensure that they're able to go through any requisite processes to join your organization. We also work within a medical leadership model so that all of our clinicians report to and work under the guidance and supervision of our associate medical director team, who are also in place to conduct a pretty intensive quality assurance process. We are regularly working within a chart review process, a medical director interview process, and a peer-to-peer collaboration process that we call citizenship review to ensure really two things. One is that the quality of care that our remote clinicians are delivering under the banner of your organization through our partnership to your patients in your community is at the highest standard of care. And second, to ensure that our clinicians don't end up on an island. The practice of medicine, the therapists and the prescribers that we employ are really accustomed to working in collegial environments where they can pop over, knock on the door, see a colleague at lunch or around the coffee pot and talk about the latest advancements in care. bounce a tough case off someone else. And we're really proud of the work that we've done to create these communication channels and engagement programs to keep our clinicians part of a community of care, to keep them on the cutting edge of what's out there, and to ensure that our clinicians are providing the highest quality care to your organization and to your patients. I also mentioned that that these programs really require ongoing proactive account management. And what I really mean by that is that you don't just find a clinician, introduce them to you, and hope it goes well. We ask for monthly, at least quarterly operational check-ins where we're reviewing a litany of items such as trends and utilization of the caseload, any specific clinical needs or demographic changes within the organization. And we're using some internal reporting functions to be able to inform those monthly meetings with SLA reports. We also proactively share with our partners our quality reports because we want to do something about them. And so we do expect that there's a relationship and communication that becomes established between our medical leadership and yours, so that they can acknowledge the areas of expertise, the areas where our clinicians are really doing a great job, and rush resources and rush solutions to areas where maybe the clinician has fallen short of our or your standards. And then finally, within the implementation step, we pride ourselves in being an organization that's flexible and provides a high degree of integration. And we do so by spending a lot of time initially working through the credentialing requirements so we can get the clinician aligned with your organization and ready to see patients as soon as possible. We've actually gone back through our 20 years of experience and teased out some critical success factors that have led to certain kind of timeframes of implementation. And you'll find that when you work with us, we'll go through that process with you to be able to give you a very specific and reliable timeframe for when you can expect services to be implemented within. And during that implementation process, we're working closely with your operational and medical leadership to understand your current workflows, your current platforms and systems that you're using. And we'll bring our library of resources and workflows to the table as well to develop a workflow for telebehavioral health that integrates within your existing workflow, but doesn't just forget that care is being delivered through telehealth. Whether the care is being delivered to patients within your physical clinic, or whether you've migrated to allowing a certain subset or all of your patient population to engage with your and our clinicians from home, there's workflow considerations, and we can help with that. And then from a medical perspective, we go to great lengths to understand formularies to work within, prescribing policies, any clinical initiatives that your organization has to ensure that our remote clinician is truly a partner and a part of that work. We always come on site and provide support and education in the week or weeks leading up to an implementation. We'll run through mock encounters with your staff and stakeholders. We'll practice the education scripts. We'll practice using the resources that you're using to educate and to educate patients and facilitate telehealth encounters to ensure that on day one, when your clinician that has been hand selected and approved by you to be a part of your organization through telehealth, that everyone who's a part of that care journey is comfortable and confident in facilitating the care. And so we've covered all the points in our agenda today. I hope that we've seen some Q&A come in. Again, as the facilitators preparing to share some of the Q&A, I want to say thank you again. My contact information is on the screen. You'll find that there's a wealth of resources on our website for telebehavioral health and the industry in general. I would please encourage you to not hesitate to reach out if you have questions or comments. I always love talking shop about behavioral health and telehealth. Have we had any questions come in?
Yes, so it looks like we have two. I will prompt you with the first one. It looks like somebody asked, what changes has your company seen with the recent pediatric psychiatry crisis, and how have you responded?
Yeah, so you guys are seeing that too. It's really been quite scary, and our perspective is national, and so we can speak to it on a national basis, but also local to Texas. And we've seen a significant increase in, again, demand and acuity of pediatric patients that are seeking care across the continuum. We're seeing higher acuity and higher complexity pediatric patients walking into outpatient clinics as established patients or new patients. We're also seeing them seek care in the ED, and unfortunately boarding in the ED for multiple days due to a litany of factors such as not a lot of inpatient beds available for them, or if they're COVID positive, not being able to access inpatient resources. So what we've done is, we've really pivoted some of our engagement and ongoing training for our clinicians to focus on that crisis. And so our medical directorship team saw the trend coming through our reports. That's kind of the benefit of having these regular reports and ongoing proactive account management meetings. We saw the trend happen and immediately huddled as a medical leadership team to say, what do we think is causing it? What do we need to do in these different care settings that we're a part of to address it? And so, as a result, we've had a lot of in-services with our clinic partners, with our community-based partners to dialogue around it. What are you seeing? What resources are available in your community? What part could or should we play? We're also offering our own guidance if applicable in those settings. And then in communities where we're working within the community setting as well as in the local hospital, we're working to make those connections to care more seamless. And so for patients that are boarding in local EDs that we're deployed within, we're starting treatment, stabilizing treatment sooner if we know that a patient is going to be there for a few days, because that patient can then get better. And in some situations, maybe even avoid the inpatient placement and keep that bed free for a patient who really, truly does need it. It's a good question. I'm glad someone asked it, because it's something we need to pay a lot of close attention to, both the acuity and complexity, but also some of the kind of suicidality of that patient population. We're on the cusp of summer, right? And summertime is historically a time where you may see a decrease in your demand from pediatric patients as they're out of school. And so really curious, and we're kind of ramping up and keeping a close eye on what happens towards the middle to late stages of the summer, as that's typically the time when the demand increases. So thank you for that question. Have there been any other questions?
Yes. So next we have somebody who asked, do you find it hard to find a child and adolescent psychiatrist?
There are fewer child and adolescent psychiatrists than adult psychiatrists. And so, yeah, I mean, we are in some ways subject to similar supply and demand factors that physical community-based clinics face. But we have the luxury, if you will, the good fortune of being able to, in some cases, recruit nationally, but deploy locally. Our founder, our chief medical officer, Dr. Jim Burrell, is a child adolescent psychiatrist. And what we found is that in any organization, when there's passion for something at the top of the organization, it almost always trickles down throughout. And it's exactly what we've seen with our organization. I think it's roughly 35% of our employed psychiatrists are child adolescent boarded. And so we're fortunate to have a wealth of child adolescent psychiatrists. And frankly, the majority of our kind of growing physician workforce comes from word of mouth of our existing clinicians. And so I think there's just a factor of having a strength of child adolescent psychiatry resources leads to more, because they typically have a network of similar level clinicians who are also eager to engage with us so that they can impact communities in the way that their peers do. Appreciate that question. Have there been any others?
Yes, the last one is a bit of a two-parter. First, can we get information on pricing?
Yes, absolutely. My contact information is right here. I'd love to have a conversation. It's not really as easy as saying it's X number of dollars. You should be aware that typically our cost structure for kind of a standard scheduled care deployment is contingent on the volume of time. And so are we talking an FTE psychiatrist? Are we talking about half FTE, as well as the level of clinician and the complexity of the patient population? The structure is also usually an hourly rate, but in collaborative care or other unique settings or program designs, we do have other financial structures that we'd be more than happy to discuss with you. I think there's a second part to that question.
Yes, and then can we get information on what working with a nurse practitioner looks like with Array as far as supervision and prescribing controlled prescriptions?
Absolutely. And I would kind of relate back to a previous concept I mentioned in terms of that. So we do work within a medical leadership model. And so in states and settings where we do deploy psychiatric nurse practitioners, they are always paired with another psychiatrist on our team. And we have a rubric for their supervision collaboration meetings. And so they're not, unstructured meetings between the psych NP and the collaborating or supervising psychiatrist. It's a subsegment of our quality assurance process that's informed by our medical leadership on how that supervision exists, and it does include a prescribing policy. Any other questions?
That concludes the Q&As that we've received. I know Maria wanted to jump back on since there were some technical difficulties on the front end.
Very good.
Hello, this is Maria of the Texas Council. I'd like to take a moment to thank you, Scott, and the Array team for your presentation today, and for introducing Array to our members, and for sharing your time. So we really do appreciate that. And we'd also like to thank you for supporting the Texas Council Marketplace sponsorship, and in so doing, supporting the goals and mission of the Texas Council. So thank you again, and we look forward to your second webinar.
Thank you for the opportunity, and thanks for the work that all of your members do. It's critically needed, and we're honored to be a part of your solutions.
Thank you so much, Scott.
Thank you all. Take care.